we have, again, doesn't matter, you can do it laying down or upright. Okay, so we got one projection, which is an AP. What's our next position going to be? Okay, we need a lateral now of the humerus. So how are we going to obtain this lateral? We're going to do it by having them turn their hand inward. So again, inward, medial rotation, thumb down, pinky up. Okay, but what is it that we're palpating to make sure that the humerus is in true lateral?
Epicondyle.
We're feeling for the epicondyles again. So here the epicondyles are going to be perpendicular this time to the image receptor. Okay, it's going to be perpendicular. Okay, again, mid-humerus, we want to include both the shoulder and the elbow joint. Now here's a slight nuance. It's hard to do this rotation and keep your arm close to the body. Naturally, what they're going to want to do is they're going to want to put their arm slightly to the side when rotating in this position. Okay? Because the arm is going more in a diagonal orientation, you want to open up your collimation just wide enough to include the elbow joint. Because remember, it's not going to be close to the body, it's going to be outward more. So open up your collimation to include the elbow. Does that make sense, guys? Okay. All right. What are we going to tell them to do? Hold still.
Don't move.
Don't move. Hold your breath. Hold your breath. Okay? Now, in an AP, we were demonstrating the greater tuberosity. What do you think will be in profile with an internal rotation? One looks at the greater tuberosity. How many tuberosities are there, or tubercles?
Two.
Two. Okay, so the true AP visualizes the greater. What do you think is going to be demonstrated in an internal?
The lesser.
Okay, the lesser tuberosity. All right. Oh. Lesser tuberosity. Okay. So the lesser tuberosity is going to be demonstrated here. You're going to get the shoulder all the way to the elbow. This isn't the image that I want. This is it right here. Okay, I apologize. Let me just go back here for just a moment, okay? Now, let's just say, for instance, your patient can't do this, okay? And it's very difficult to do. One of the optional views that we can do, because this is called the, what do you call it? It's a lateral medial projection. Lateral medial projection. Now, if they're unable to do this, we can do a medial lateral projection. Entering the medial side and exiting the lateral. And it's done something like this. Okay? So that just allows them to just simply place their isolated arm up and just out of the way. Much tougher to do this, right? So if you have a patient coming in with some trauma or some pain, we can do this. We could do the opposite lateral. Okay. Again, key here is that we're in a diagonal, so you want to open up your collimator from side to side to include both the shoulder and the elbow joint without cutting it off. Okay, and this is what this particular image shows. Okay, so this is a medial lateral projection. The epicondyles are going to be superimposed, including both the shoulder and the elbow joint, and the lesser tubercle is going to be projected medially. Projected medially. And we know it's a tubercle, lesser tubercle, because it's going to be what? More inferior, more lower. Okay? Greater is superior, lesser is inferior. And it's harder to see in this particular image because of the increased density there at the shoulder. And so this is what it looks like if we were to just look at the shoulder. The lesser tubercle is going to be inferior and more medial. Okay.
That's the other one, the other image?
This just no, I'm just showing you, this is just a separate image of the shoulder to demonstrate, because remember we said we couldn't see it here. So this is just an isolated picture to show you the lesser tubercle that's medial in this particular arm position. Okay, so after you guys take your images, take an x-ray, when you go back into the room, what are you going to tell your patient to do?
Breathe.
Okay, so don't ever forget to tell your patient to breathe. because some patients follow directions to a T, okay? And unless you tell them to breathe, they're going to keep holding their breath for you. And they'll go, "Ugh, can I breathe?" Okay. All right. Here's a trauma image, okay, of the humerus, where someone can't pull those positions for you. Okay, because remember, one is this and the other one's this. In someone who's traumatic, we need to take two separate images of the one arm. One will be of the distal humerus, and this is known as the traumatic projection, okay? So patient is going to be lying on their side, for example. We're going to place the image receptor between the arm and the body, okay? And we're going to have them, either you're going to prop up the image receptor, or if they can hold it for us, that would be even greater. Okay? So this particular projection is a trauma horizontal beam lateral medial projection of the humerus. This is going to demonstrate the distal two-thirds of the humerus. Okay? Have them try to flex their elbow. Again, if they can, then you can. Central ray is going to be at the midpoint of the distal two-thirds. In other words, you're not going to go at the middle of the forearm. You're going to be at the middle of what? What's going to be your marker point here?
Above the elbow.
It's going to be at the middle of the image receptor. Okay? So this, you may be projecting here, but you're actually centering to the middle of your image receptor. Okay? Center of the image receptor. Have them hold their breath. This is what it's going to look like. Okay, it's just going to be a distal two-thirds of the humerus. Now, this is in a traumatic situation, again, where the patient can't move their arms for you. Now, if we've got the distal two-thirds, how are we going to get the proximal third? Because we can't get the set way up in there, right? We covered this on the very first day of class. You guys remember this projection?
It's transthoracic.
It's the transthoracic. So now what we're going to do here is we're going to shoot through the chest to visualize the proximal forearm, proximal humerus. Okay? So the patient can either be upright or, again, in a supine position. The unaffected arm is going to be raised, while the affected arm is going to be closest to what?
Image receptor.
The image receptor. So unaffected arm up, affected arm closest to the image receptor, and we're going to shoot right through the chest.
What if both arms are trauma?
If both arms are trauma, then you're SOL. We got to figure out a way how to do that. And usually what they'll do is we can probably get one projection, which is an AP, and then we go from there. Okay? But we need to figure out how to do the second one. Yes?
On the previous projection, is that screen model? That screen?
Do you guys know what happens when you magnify an image? It also applies here on here. Because remember, magnification, you start to lose detail, and it gets real blurry. So this is a small picture that's been blown up. That's all.
For the transthoracic, do we use longer exposure times because we're having them breathe?
Yes. Okay. So we're going to get back to that. So here you're going to do transthoracic, unaffected arm up, affected arm closest to the image receptor. You're shooting you're shooting through the chest. Okay, at the level of the mid-humerus. Well, how do I know where the mid-humerus is if my arm is up? Well,
Look at the shadow.
I heard it. Well, center it when the arm is down, okay, mid-humerus, and then raise it up. Okay, that's how you know you're mid-humerus. If you're mid-humerus here, you're going to be mid-humerus here.
And they're all crooked.
Right. Should be at the same level. So do it like this first, and then raise their arm. Okay, so you're going to center at the mid-humerus. So came about the question or the comment about breathing technique. So yes, we want a breathing technique. So what is a breathing technique? It means the patient is
Breathing.
and you're going to use a
Longer technique.
long exposure. Now remember, just because you have a long exposure, does that mean that the patient is getting a lot of exposure?
No.
Because when you increase your time, what are you going to do with your MA?
Decrease it. Decrease it.
Decrease it. So it depends on how much you increase your time. Okay? But what law is this?
Reciprocity.
The reciprocity law. As long as the total mass is the same. This allows you to manipulate time. So when you increase time, you decrease MA. When you decrease time, you increase MA. As long as the total mass is the same. So even with a longer time, I'm going to shoot this at 4 to 6 seconds. Beep, while they're breathing, and the long exposure and the breathing is going to do what?
Blur out the lungs and the ribs.
It's going to blur out all the surrounding structures. So the heart, the lungs, anything around that area, while the humerus stays in focus. Okay? Anything wrong with this image?
Bad fracture.
That's a freaking fracture.
Fracture and a half.
Yeah. Where do you think that fracture is?
Oh, the surgical.
At the surgical
neck.
neck. This is right at the surgical neck. So this is done with the patient laying down on their back. Okay? The affected side was closest to the image receptor. Okay? The other arm is up and out of the way. Breathing technique. It blurs out the surrounding structure while keeping the non-moving part in focus.
So you could do a transthoracic laying down as well?
You can do it upright, you can do it laying down.
Once we ever get a patient like that, would it be normal that they've already had like painkillers administered or no?
I don't know. I mean, would it be normal? I don't know. It depends on what the ER doctor wants to do. Sometimes you can send them straight to the radiology department without having to do a thorough checkup. So they may be in a lot of pain. Sometimes you get them when they're completely knocked out. Yeah.
Do you have to label the table as opposed to upright?
Label it upright, you mean?
Well, like you said, this one like laying down and it says table. Is that
Oh, this is cross table, meaning that the cross table meant they were using it horizontally.
Do
Yeah,
you have
do
to
I do?
specify that, or-
Well, you should let them know that it was shot horizontally and also transthoracically, just so the doctor knows. I mean, he or she is probably going to be smart enough to figure that out. Yeah. But it would be nice. It'd be nice, yeah. Okay? So again, we want to include both joints from the shoulder all the way down to the elbow. Now, especially here, when you're shooting through the chest like this, you want to use some tight collimation. Because when you're shooting through something that's very thick and very dense, what is the tendency? What is it going to produce? Scatter radiation. And scatter radiation increases density. What happens to the overall image? It becomes very gray, and you're going to lose some of that, what, resolution? So I'll review, guys, right?
So even with digital, you still get film, you still get fog?
You're still going to get, well, you're
Or-
going to lose, you're going to
or
get
you-
some loss of detail. Will you get fog? Probably not.
'Cause that's with film, right?
Yeah, but also when you're collimating, you're also protecting the patient because with increased scatter radiation, the patient's receiving all that. So we're doing this not only for the sake of beautifying the image, but we're also doing it for patient protection. Okay, any questions, guys? All right. Yes?
Can you go over the medial lateral section?
Medial lateral? Yes, I think we did this one. That one. Yeah. We did that one. So again, you have two sides, so you can approach it from the lateral side or you can approach it from the medial side. And you have to assess your patient to see what they can and cannot do. So in this case, we'll do this projection because they're not able to do their hand rotation for you. Okay. All right, guys, let's go on break. Come back about 11.